Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei niin kuin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Good afternoon to everybody and welcome to this webinar. I'm Dr. Chiara Robba from the University of Genova in Italy, and I'm really pleased to present and to moderate this afternoon session. I think that we are going to deal with a very important topic from a clinical perspective, which is the management of stroke and in particular the intensivist point of view. And I think it's very important because despite there has been a reduction in mortality and disability adjusted life years over the last decades, acute ischemic stroke remains the third leading cause of death and major cause of permanent disability worldwide. And intensivists are fully involved in the management of the sickest stroke patients. And even in those with more severe strokes, there is a bundle of medical and vascular and surgical strategies that when are applied in a timely and consistent manner can actually improve long-term outcomes. And I am really proud to present you today two great speakers who are Professor Raimund HELBOK from Innsbruck, Austria, and Professor Sung-Min CHO from Baltimore, USA, Johns Hopkins. And they are going to bring us to a huge and important discussion regarding this topic. So I will start with the first speaker. The first speaker is Raimund HELBOK, as mentioned, and in the next 15-20 minutes, he's going to discuss with us about the revascularization and initial ICU management. Raimund, the audience is all yours. Thank you.
Thank you very much, Chiara. First of all, also very warm welcome. Good afternoon to everyone listening to this talk. Chiara, thanks for the nice introduction, and thanks for the NIC section and the European Society to organize this session, important session, view from the intensivist on stroke management. So as Chiara said, I'm Associate Professor of Neurology and Neurocritical Care, and I'm living in a city, a rather small city, but as you can see here, also in the picture, we are surrounded by mountains. We have a lot of helicopter services, and which are obviously of benefit not only for the tourists, but also for stroke management for patients in this area. So I don't have any conflicts of interest regarding this talk, and as neurologist from training, I have to start with the clinical exam. I think the clinical exam already tells us a lot, and what you can see here is a patient, the feet of the patient, also a puppet where you see that something is wrong with the lower right extremity, and also a gaze deviation. So if you see that, you know that something is wrong in the left hemisphere of this patient, but you don't know whether the actual cause is an ischemic stroke or an intracerebral hemorrhage. And this is the first important message, take-home message, that so far we cannot differentiate between ischemic stroke and intracerebral hemorrhage. We need neuroimaging. And if the neuroimaging is negative, stroke is a possible cause. And as you can also see here in the images, you see an hyperdense media sign. So this patient has an MCA stroke, an M1 MCA occlusion with the clinical presentation and the radiologic examination. So as Chiara pointed out, time is brain, and that's why even though I should present the view of the intensivist, I think it's important to know what's happening on scene, and we do have the golden hour after stroke. So rapid management, even in the pre-hospital area, is of utmost importance. So the American Stroke Association and the European Stroke Organization defined 8 different domains of stroke management, which should be implemented in several areas in the world. And I think that's an important paper which covers the pre-hospital phase, which even covers primary, secondary prevention, stroke rehabilitation, until quality of care management. So what's happening on the scene? And in fact, in the area of thrombectomy, there are different ways how a patient is managed in different countries. So there is the mothership principle where the patient is directly transferred to the thrombectomy center. This is capable in some areas, and the other hospitals are bypassed. But many hospitals still have the condition that the patient is first transferred to another hospital and then to a thrombectomy center. And there's some trials investigating whether the one or the other management is better, and there's no scientific clue for now or no scientific answer. What happens rarely is that the neurointerventionalist is actually going to the other hospital, which usually does not provide thrombectomy. And what is kind of a future expectation and also some times already realized is a system where mobile stroke units are on the way to put the patient on the CT scan in the car and then already to transfer the patient to one or the other center. And this is a system, and there are ongoing studies which investigate the pre-hospital care with a rapid diagnosis of neuroimaging in the car already, which is in place in some countries, has obviously not a large capture area, but brings us some information that the symptom onset, so stroke onset, to the application of the treatment is significantly diminished. And this is actually what we want to reach. But obviously it's costly, and you also need the pharmacy, and you also need the neuroradiologist, so someone who can read and interpret an acute CT scan on board. So what is the evidence so far? As discussed, the reduction of symptom onset to thrombolysis time. The triage decision should be 100% correct in terms of the identification of stroke. And in terms of the outcome, there are some data which are partly published, partly unpublished, which also show a benefit in terms of improved outcome. But as I said, this is only applicable for large cities, but in future we have to discuss about this method more. So once in the hospital, you know that neuroimaging is important. We have to discuss the aspect score, which is graded, especially in the setting of clinical studies. And the grading is towards whether the patient is still eligible for thrombectomy or for thrombolysis. We count 10 different areas, and every normal area gets a count of 1, and the maximum score is 10. But what is more needed is the communication about stroke severity, and we use the NIH stroke scale. This scale should be quantified in the beginning, so when in the early clinical presentation, and obviously after a certain time period we have a scheduled approach when to evaluate, especially before treatment and then after thrombolysis, for example, and also within 24 hours. So as communicated, even as ICU doctor, what is important that you have a proper communication to the pre-hospital area. And in our area, we usually get informed that the patient suspected with stroke is going to be transferred to our unit, to the emergency room, or transferred via helicopter. And from that time, the clock counts. And this is an important time where we have to improve the management principles. And what international standard says, we should not take more than 30 minutes for all what we have to do in this time period. So taking a history, looking at vital signs, blood pressure, important, the neuro exam, the most important laboratory information is glucose, because hypoglycemia can mimic stroke. And obviously there are also additional information on the laboratory analysis, but the pretest probability for a young person is very low to have a thrombocytopenia. So sometimes this is not necessary in a certain patient population. Head CT scan should be performed as soon as possible. And the best to save time is already taking the drug with you into the CT scan, and then the preparation of the TPA and injection, even already starting in right after neuroimaging. That's at least what we do in our unit. So for the early phase, the first take-home messages, brain imaging is important. You only need a non-contrast enhanced computed tomography, although we know that CTA is usually performed in many centers and MRI scanning as well. But in general, it's not needed. There are other technologies as well, but in the area of thrombectomy, CTA is performed in a lot of patients already at the beginning. Neuroimaging should be performed rapidly in the majority of patients within 20 minutes, and laboratory analysis, the most important is blood glucose, and all the other parameters still depend on the patient, but also on the local procedure. So IV thrombolysis, we know that we applied thrombolysis for time window stroke onset to application for 3 hours for a long time. Now the window is up to 4.5 hours. We know that at a certain time, the number needed to treat is too high, and we also may harm the patient with a higher risk of intracerebral hemorrhage. And there are some trials which were published some years ago and which were very important before the area of thrombectomy, and now obviously less important, but we learned a lot from these trials that even a time window beyond 4.5 hours makes some patients, a subgroup of patients, eligible for thrombolysis treatment. And how to identify these patients in the study population. This is the diffusion as shown here in this color, and in the greenish color, the perfusion. So when the patient has a diffusion-perfusion mismatch, then one might also apply the thrombolysis for a prolonged time period. These are the summary of the study, which showed that improved outcome is still observed in these patient populations, but on the other hand, also an increased risk of intracerebral hemorrhage. So in summary, for thrombolysis, there are some limitations. We have a limited time window. We can extend the time window, but this has been discussed now. It's contraindicated in patients with novel anticoagulant treatment, although we have dabigatran as antidote and can apply that, give the dabigatran and thrombolyze the patient afterwards. Revascularizations, if we look at the patient, at the data, is partly limited, and especially in proximal vessel occlusion, we see that the recanalization rate expected is very low. And if it comes to a large thrombus size, more than 8 millimeters, but in general, a lot of patients have large thrombocytes, especially in the proximal vessel occlusion, the recanalization is not very effective with the thrombolysis treatment. And now, since several years, there are several studies, altogether 7 studies, which show the positive effect of thrombectomy, of endovascular treatment with stand retriever aspiration or a combination, which showed that with this method we can provide a better care for patients and improve outcome in terms of good outcome. You see the absolute difference in benefit for a modified ranking of 0 to 1 and 2, which is a huge benefit for this subgroup of patients, and also reduction in mortality. And at the beginning of these thrombectomy trials, there were 3 trials, which were actually negative trials, and Mr. Clean was the first positive trial, and then followed by other trials, which were also partly halted because of the proven benefit of thrombectomy in the acute stroke management. And that's why the guidelines also updated their recommendations that, especially in clinically relevant neurologic deficit and proximal vessel occlusion, thrombectomy should be performed in stroke patients. The benefit is also that it's possible in patients with novel anticoagulant treatment. The time window is extended. It's 6 hours in the anterior circulation. I'm talking about the prolonged time window then afterwards. In the posterior circulation, it's even up to 12 hours, but obviously in basilar stroke, you don't lose a lot if you provide a thrombectomy, but it's clear if there is a prolonged time in coma that there is no proven benefit in terms of outcome. Bridging is possible and is still performed in many patients, so in many centers, meaning that first thrombolysis is being performed and then thrombectomy. And we don't have a study who shows so far that thrombectomy, a single approach, is the way we should recommend for every region in the world to be performed. This is the situation in Austria. It's a small country, and we are very much helicopter-based, especially in the area of Tyrol. And if you can see our stroke data in the last year, more than 1,300 patients, it's interesting to see that still only 1/3 are in the emergency room within 3 hours, obviously more within 4.5 hours. Thrombolysis rate 20% in our hospital. And in the subpopulation, which are properly eligible for the intervention, you see that our thrombolysis rate is close to 70%. How many patients undergo thrombectomy with an angiography? You see between 5 and 6%, which is also internationally known to be the approximate amount of patients for this treatment. So what about an extended time window for endovascular treatment? There are 2 trials which I referred to, and also the recommendations of the American Stroke Association, which are so-called wake-up trials, where with an extended time window for the intervention of thrombectomy, and the diffuse 3 trials up to 16 hours, and the dawn trial up to 24 hours. And the important information that you have to identify the correct patient population by the mismatch volume, which is well described in the methods of the study, or depending on age, clinical presentation, and infarct size. How many patients are that? We looked also at our data sets. It's an estimated rate of additionally 2% rate of thrombectomy per center. What about subgroups of patients? That's an important information. This is a meta-analysis of patient individual data. What about patients aged 80 years and older? So you see here that there still might be a benefit for this patient population. Also patients with a prolonged symptom onset. Those patients who are not eligible for alteplase, and obviously these are the novel anticoagulant treatment, for example, or other reasons. And the question still remains for the younger patient population. That's interesting. Obviously, the younger patient populations is in clinical practice also eligible for this intervention. What about patients with a low NIH stroke scale? The recommendation goes towards if that is a relevant finding. So, for example, in aphasia, still the intervention of thrombectomy is recommended. What about more peripheral occlusion, not M1 occlusion? So I'm talking about M2 occlusions. And in fact, there are some studies, especially summary of the randomized controlled trials with the subgroup information, which show the benefit for this M2 vessel occlusion. And this is also the recommendation now, which is provided by the American Stroke Association. So there's the argumentation is that the mechanical thrombectomy in this subpopulation was still significantly associated with good functional outcome, and none of these patients in the study at least had experienced symptomatic intracerebral hemorrhage. But what is important to discuss, revascularization is one thing, and the clinical presentation and complications are another point. And especially the risk also for intracerebral hemorrhage in the prolonged time window is an important complication which every intensivist should know. And there are also some data which show that patients with a fibrinogen deficit after the thrombolysis have a high risk of secondary hemorrhagic transformation of the stroke area. So there are several studies also, or several authors also asking the question, can we predict or identify those patient population which do not benefit from this aggressive or more aggressive treatment? It's very difficult to say in a patient level, but here's some information with risk factors for poor outcome even after recanalization. And there's one additional information. What about tandem lesions? First, the explanation. What is a tandem lesion? A tandem lesion is a lesion here on the internal carotid artery, and then in addition, intracranially, like the M1 occlusion, as you can see here. There is obviously the recommendation first performing a thrombectomy intracranially for reperfusion, and then even with stent application in the internal carotid artery. But what is needed with stent application, a more aggressive thrombocyte blocking agent. So what you can see here in a patient which is also admitted or treated in a hospital with aspirin and clopidogrel, you see this symptomatic intracerebral hemorrhage which worsened the clinical condition. And this is something we enter now a more aggressive treatment, and obviously we see more side effects where the intensivist then has to take care of. If it comes to the ICU, I will only cover general management ideas and the very initial phase. So important, we want to prevent secondary brain damage. And one of these part is an appropriate airway management, not only during the thrombectomy. There are some studies which compare conscious sedation versus intubation during mechanical thrombectomy. And there is no clear answer, but some institutions perform more mechanical ventilation during thrombectomy. And we try to prevent thrombectomy if the patient is in appropriate compliance. What has to be known that oxygen supplementation is important, but obviously not too high oxygen. Airway management is important, especially in patients with reduced level of consciousness. But for example, an MCA stroke never reduces consciousness unless you have the malignant edema. So whenever you have an MCA stroke patient and with a decreased level of consciousness, you have to look for additional causes or maybe also an occlusion of the posterior circulation. Management of aspiration is very important, especially in stroke patients, as pneumonia is associated with worse outcomes. So infectious surveillance is important, prevention of pneumonia. And whether to tracheotomy or tracheostomy a patient very early or late, there is also an ongoing discussion. For me, it totally depends whether you can triage the patients on tracheotomy to rehabilitation centers or not to perform this intervention early. Blood pressure monitoring, continuous monitoring is obviously important. There seems to be an optimal area of the systolic blood pressure. Too low is associated with poor outcome and also too high. If we start at the beginning, if we apply thrombolysis, we have this maximum blood pressure level, which should not be more than 185 systolic blood pressure. In the case where we cannot put the patient on thrombolysis, we may not lower the blood pressure too low. During revascularization, systolic blood pressure around 160 millimeter of mercury is recommended. And after recanalization, obviously, we have to prevent the hypervascularization, which increases the risk of intracerebral hemorrhage. And here are some drugs which could be applied for lowering the blood pressure in these patients in the ICU or acute management during thrombectomy. And other principles, how to treat these patients, I think these follow the principles or the recommendations of what has to be done in neurocritical care patients, so normal bulimia, normothermia, a strong prevention of fever, targeting normal temperature, normal glycemia. I put a higher level because prevention of hypoglycemia is very important in this patient population. And also, if you look at the advanced neuromonitoring studies, in some patients need a higher systemic glucose level, eunatremia. And before I stop the talk, these are the last slides. I want to focus your attention on a rather new phenomenon, which is called spreading depolarizations, which are electric waves over the cortex, which progress on the cortex in a very slow manner and can significantly decrease the activity of the brain. And if they are rapidly one after the other, we call them clusters. And these clusters are associated with secondary brain injury. And especially in stroke patients, we do have animal data and patient data that the ischemia is triggering these cortical spreading depolarizations. And as shown also here in this study, the DWI extent of damage significantly increased associated with these cortical spreading depolarizations. But we don't know whether this is an epiphenomenon or causality, but as also shown in patients with traumatic brain injury, subarachnoid hemorrhage, we more and more believe that this phenomenon is important phenomenon in which we should take into account in the prevention of secondary brain injury. For now, monitoring is only possible invasively, but if you follow the general recommendation of prevention of fever and normal bulimia, this is already an important first step. So in summary, stroke is a neurological emergency. You have to think about these acute management, how to decrease the time until you apply the appropriate treatment. I talked about neuroimaging. All these patients should be admitted to a monitoring unit, which could be a stroke unit for awake patients or ICU in more severe cases. I did not and will not touch on craniectomy, as this is the topic of the next speaker, and the general principles of the critical care management of normothermia, normal glycemia, and normal bulimia. And having said that, I would like to thank you for your attention and also mention that we enter a more aggressive treatment in terms of other pharmacological treatment, which are coming and will come in the next years, and which actually put more importance also in the ICU care of these stroke patients. Thank you very much for your attention.
Thank you, Raimund. Really an excellent presentation. I will leave the room for the questions at the end of both the presentation. So I will ask to Professor Sung-Min CHO to share his slides. And Sung-Min is a consultant in neurointensive care at Johns Hopkins in Baltimore, USA. And he's going to discuss with us over the next 20 minutes about the management of brain edema after large MCA stroke. So one of the most life-threatening complication of acute ischemic stroke. Sung-Min, please, you can start. Thank you.
Thank you so much, Chiara, for the introduction. I'm a neurointensivist at Hopkins. I'll be talking about today how to manage brain edema after large MCA stroke. My disclosures. This is the outline for the talk today. We'll be talking about cerebral edema, clinical signs and symptoms, risk factors, and how to medically and surgically manage these patients, and further research and directions. So let's talk about a little bit of cerebral edema history. Long time ago, Robert Witt and George Cheney, they described excess intracranial fluid that can occur without enlarged ventricles. And this is probably the first description of cerebral edema without the terminology. They described it as a soft appearing brain. And of course, we know famous Monroe and Kelly doctrine. We'll be talking about that a little bit more in the later slide. And Paul Ehrlich, he identified blood-brain barrier, BBB, with aniline dyes in 1886. This is important because it has an implication on different types of edema. And following a long time later, Becke and Lee, neuropathologists, they described two different types of cerebral edema by electron microscope. And then finally, Igor Klatzo was a Polish neuropathologist, 1967. He described two different subtypes, cytotoxic and vasogenic edema, and he termed this specific terminology at the time. And he was actually in the NINDS, very close to where I live in right now, and he was a chief of laboratory of NINDS at the time. What about malignant MCA? The term malignant was first used by Heck et al. To characterize the complete infarction of the middle cerebral artery, MCA territory, with space-occupying mass effect that can develop for several days. It can be just a large MCA infarction, but it can involve also ipsilateral ACA and PCA territories. It turns out it's not uncommon. 5 to 10% of all ischemic stroke develop malignant infarction. And if you have a large vessel occlusion, that's a big risk factor for developing malignant MCA or malignant infarction, especially MCA occlusion, proximal M1 occlusion, and also ICA occlusion, which includes both entire anterior circulation in one side. And of course, because of this is malignant infarction and cerebral edema, it causes elevated ICP and brain herniation, which has a really clinical implication in the long-term disability and death and mortality, up to 80% in this population. Let's talk about cerebral edema in ischemic stroke. There are different phases. We usually talk about cytotoxic edema for ischemic stroke patients. It occurs minutes to hours, and the pathophysiology for cytotoxic edema is they usually have intake BBB, but really the swelling of neurons and glia cells due to failure of ATP-dependent ion transport channels, notably sodium and calcium. And then after that, following that, it causes endothelial dysfunction, and there is an ionic gradient between plasma and interstitial fluid, and it causes extracellular fluid accumulation. And lastly, vasogenic edema occurs after 1 or 2 days after the ischemic stroke onset, and it's characterized by breakdown of BBB and extravasation of serum proteins such as albumin. What about the clinical symptoms and sign? It's all about neuroanatomical localization, and previous speaker really described really well about the anatomical localization. But most important clinical parameter for this subpopulation with malignant MCA or malignant infarction is probably level of arousal and mental status. So as an intensivist, when you admit this patient in the ICU with a huge MCA or entire hemispheric infarction, it's really important to monitor their mental status. If they have increased drowsiness, depressed mental status, you have to suspect there is a massive effect to ascending reticular activating system, and that's causing a lot of issues with the mental status. Of course, there is confounders, right? For depressed mental status, CO2 matters. If you have a hypercapnia, that can cause a drowsiness. Fever always clouds the mental status. A seizure is very common with ischemic stroke. Even acute ischemic stroke that can also present with a seizure. Sedation is always a challenge in ICU, and we'll be talking about that a little bit more in the later slides. In patients with right MCA stroke or right hemispheric stroke, it's important to recognize there is central ptosis and eyelid apraxia, which is different than true decreased mental status. Let's talk about risk factors for developing malignant MCA after ischemic stroke. There are some neuroimaging markers that's been done over the years. Early MRI turns out to be very valuable in predicting worsening outcome in these patients, especially diffusion-restricted imaging. More than 82 cc at 6 hours when MRI was done at the time was the most powerful predictor for malignant evolution with fairly high specificity. If you do diffusion-weighted imaging at 14 hours, more than 145 cc were pretty highly sensitive and specific in evolving to malignant infarction. As I alluded to before, having a large vessel occlusion is a big risk factor for developing malignant infarction, especially ICA occlusion and proximal M1. And size matters, multiple territories, and really having deep structures or not, it matters because it compresses thalamus and brainstem lesions. And age matters, right? The older patients have cortical atrophy, so they have more space to swell. But younger patients, they have less space to swell, so they can have bigger implication when they have cerebral edema. NIH more than 20 in dominant hemisphere because of aphasia, more than 15. Really, this is really correlating with the multiple territories or size of the stroke and LVO. And some studies have mentioned that high blood pressure within 12 hours, refractory high blood pressure is a risk factor for having malignant infarction, along with nausea, vomiting in first 24 hours, which is maybe a sign of increased ICP. Coming back to Monro-Kelly doctrine or hypothesis, which state that sum of volumes of brain and CSF and blood is constant. So increase in one should cause a reciprocal decrease in either one or both of the remaining two. So as you can see, when CSF and blood is compressed and they're exhausted, the mass effect will cause brain to be compressed and with confine the skull in the brain. For the brain, really there's nowhere to go and it's going to cause a significant compression and herniation. What about the neuroimaging marker? We can do MRI on these patients many times, in a timely manner. CT scan is really the way to go. How to recognize cerebral edema and midline shift is the key. Seminar paper by Roper, NEJM article 1986, really how to measure midline shift and compared septum pellucidum and pineal gland to measure the midline shift. And contrary to traditional concept at the time, a couple of decades ago, where transtentorial herniation may be thought of as a really big factor for predicting mental status, but really early depression of level of alertness, it turns out horizontal displacement at the level of pineal gland was the earliest and most consistent distortion of the brain affecting reticular activating system. And as you can see in the graph on the right side, the pineal gland, 3 to 4 millimeter predicted drowsiness or correlated, 6 to 8.5 millimeter with stupor, and 8 to 13 millimeter with coma. So it's really important when you have a depressed mental status, CT scan and look for pineal gland and look at the mental status and make a decision based on that. How to manage these patients? First thing is triage. Thrombolysis thrombectomy was already discussed in the first session beautifully. It's always important to talk to family, right? Family and next of kin about their wishes, especially older patients. And they're always the physicians and medical team have a shared decision-making process with the family members, which is a guideline recommended by AHA guideline, a strong recommendation. And also having a neurocritical care unit and frequent neuro monitoring and checks, and also to transfer this patient where neurosurgical expertise can be provided for hemicrania is really important to improve this patient's outcome. Early ICU evaluation, we kind of talked about this in the previous session already, but in the ICU, we all know first thing is airway, breathing, and circulation. That's the most important thing when you assess this patient. When they hit the door, airway, breathing, circulation is what we need to do. And frequent neuro exam for high-risk patients. We talked about the risk factors, early identification and timely intervention is the key, especially if your center offers early MRI, really offers the patients or us to predict which patients will do better or worse in the next couple of days. So medical management with oxygenation, avoid hypoxia is always important in patients with cerebral ischemia. Hyperoxia is a controversial topic, but there is some observational data that hyperoxia more than 300 PaO2 is associated with higher mortality, but probably a subpopulation that may be very interesting is thrombectomy patients after reperfusion. What does hyperoxia do to reperfusion, reperfused brain tissue, and does it cause more reperfusion injury or not? Maintaining normal CO2 is important. As you know, CO2 is a potent vasodilator in the brain. So if patient is intubated and tidal CO2 monitoring is important. Avoiding hypercapnia is really important in this population, especially patient at risk for developing ICP issues. If patient is intubated, minimal sedation to make the patient as comfortable as possible is important. Precedex would be a nice medication to follow neuro exam and not to confound too much on neuro exam. Only permissive hypertension is the common practice, as we mentioned before, 220, 120, but there are a lot of limited data. Probably, we have to really study more in optimal blood pressure in the setting of autoregulation function, and it's the dynamic process. Normothermia, avoid fever. Fever worsens the infarct burden in ischemic stroke patients. We should avoid fever as much as possible. Avoid shivering is also important, not to increase the CMR2 of patients with ischemic burden. And we talked about hyperglycemia. 80 to 180 is really the range to target based on the SHINE trials a couple of days ago, which compared 180 versus 130 target. Briefly, let's talk about blood gases. We talked about this a little bit already. CO2 is a potent vasodilator for brain. So maintaining normal CO2 is important. And as you can see in the graph, PaO2 less than 50 really causes also vasodilation. And it has a lot of implication and significance in controlling or affecting the function of cerebral autoregulation. PaCO2 and PaO2 should be monitored closely in this population. And cerebral autoregulation, it turns out to be a very dynamic process. Blood pressure is always, of course, an important area of research in ischemic stroke patients. Permissive hypertension is what we are doing and what we are practicing after ischemic stroke. And TPA and post-thrombectomy patients have a different target for these patients, which I will not get into. But surprisingly, really limited data exists what the optimal blood pressure target is for ischemic stroke patients. And the studies have found mixed results on the evolution of dynamic autoregulation change in the acute ischemic stroke phase. Especially these patients go through different phases, right? After thrombectomy and revascularization, really early period, they have different dynamics in autoregulation. And then first 48 hours, and then after a couple of days, that also has a different implication in outcome in relation to autoregulation. But there's really limited data looking at autoregulation and optimal MAP or blood pressure in different phases of ischemic stroke patients going through. And of course, comorbidity like hypertension, pre-existing CHF, diabetes, age, sex, all these factors impact autoregulation. Let's talk about hypothermia in ischemic stroke. In the light of TTM2 in cardiac arrest, hypothermia is always a hot topic in the ICU. Ischemic stroke, short conclusion is there's not much data or benefit of using hypothermia in ischemic stroke. Of course, therapeutic hypothermia provides neuroprotection after ischemic injury, right? A lot of mechanisms. It decreases metabolism in the brain, suppresses glutamate release, and reduces neuroinflammation, and it affects the apoptotic pathways and also reduces free radicals with reduction of edema formation. So in animal studies, I mean, it turns out it should be helpful, but in clinical studies, it did not really translate in ischemic stroke. Most notably, Kool-Aid and ETOX study, early clinical trials really supported safety and feasibility, but did not show benefit on these patients. I'm showing the table, a summary of the studies that's been done clinically. So you have this patient, malignant MCA, they developed cerebral edema. Really, the next step is when they develop ICP crisis or they are at risk of having ICP, really we need to manage this brain herniation, increase ICP. Recognizing Cushing's reflex is important, irregular breathing, hypertensive, and bradycardia is very important. And if you identify ICP crisis, then you have to manage these patients. First, you have to improve venous return. Positioning is important, not to block venous return of the jugular vein. And anxiety, pain, seizure control is important, so you can reduce the CMRO2. Decrease arterial blood volume, hyperventilation is very effective in reducing ICP, but this is only transient. And recognizing hydrocephalus and pressure issue is really important in this population, especially hemorrhagic conversion and IVH. You would want to do EVD, which is a life-saving measure. Brain parenchyma, the hallmark of medical therapy is hyperosmolar therapy, mannitol and hypertonic saline. We're gonna talk about this more a little bit later. And decreasing CMRO2. If everything fails, therapeutic hypothermia, birth suppression with pharmacological coma is the rescue therapy for managing refractory ICP. But probably most important thing for malignant MCA or hemispheric infarction is really surgical intervention and decompressive cranium. Let's talk about osmotic therapy a little bit briefly. There's no evidence for using this as a prophylactic therapy, but a lot of centers do. I've done that, but really there's no data for that. And osmotic therapy is mainstay for reactive medical therapy when you have progressive brain swelling with clinical symptoms of ICP issues. And it's weight-based, bolus dosing 1 to 1.5 gram per kilogram IV, usually done Q4 to 6 hours. And you have to remember mannitol is a diuretic, so you have to catch up with the fluid not to cause hypovolemia in this population. Hypertonic saline is commonly used, gaining more and more popularity over mannitol, but in real life, probably you're going to use both. When there's ICP crisis, we use bullet, it's called bullet, 23.4% saline to reduce the ICP. Mechanism for mannitol is it draws water from interstitial and intracellular space from the brain across BBB, improves microvascular cerebral blood flow by hemodilution. In the animal studies, it was shown to improve infarct volume, edema formation, and also it helps with the ICP. We usually target serum osm 320, and if it is above 320, we tend to hold additional doses. Osmolar GAB is probably a better target though. 10 to 15 osmolar GAB is a reasonable target for these patients. And the calculation for that osmolar GAB is in the slide. Hypertonic solution, very effective in expanding intravascular volume with increasing blood pressure. And it subsequently it improves CPP as well. But again, both mannitol and hypertonic saline, surprisingly little data exists to address its long-term outcome in this, how effective it is. We know that it helps with the ICP and CPP. It's really old study a couple of decades ago looking at 16 hypertonic saline hydroxyethyl starch treated events and 14 mannitol-treated events. If you look at the graph, ICP really improved both of the groups, mannitol and hypertonic saline treated groups, and ICP improved faster and lower in the hypertonic group compared to mannitol group, and CPP was better in mannitol treated group compared to hypertonic saline. But both of these groups, as you can see, ICP and CPP was improved after mannitol and hypertonic saline, but there is really no long-term data in ischemic stroke population. There's some data in TBI population. So guideline is a use of osmotic therapy for a patient who has neurologic decompensation with brain swelling is reasonable. There's a moderate recommendation and limited data. They recommend also hyperventilation for ICP patients with ICP crisis, probably target of 30 to 34. And they mentioned that hypothermia and barbiturate in the setting of ischemic cerebral and cerebellar swelling are not recommended. But if you have a refractory ICP crisis, it can be considered and be performed. I want to briefly talk about anti-edema drugs. So as you can see in the graph, there is a lot of pathways. A lot of people were interested in really targeting specific pathways to reduce the edema in ischemic stroke population. Right now, the key mediators throughout the animal studies and clinical studies is really focusing on this receptor, sulfonylurea receptor and transient receptor potential myostatin, TRPM4, which is a non-selective cation channel that's expressed in CNS under conditions with ischemia, hypoxia, and trauma. This channel opens when there's a depletion of ATP. So this channel is really can be blocked by sulfonylureas such as glyburide, which is a motivation for this study that was done by Kevin Sheff in Yale, phase 2 GAMES RP study using glyburide to target this pathway so it can reduce the edema and potentially improve the outcome. The primary outcome was MRS 0 to 4. There was no difference in primary outcome between the groups. For those patients who did not underwent decompressive hemicrania, although mortality at 30 days was significantly reduced. There is a phase 3 trial ongoing, CHARM trial, so we'll see if that helps or not. Let's talk about surgical trial, landmark trials, Decimal, Destiny, and Hamlet. It's a pooled analysis that was published in Lancet 2007. You can see all patients included in the pooled analysis. Really, there is a significant improvement in mortality when hemicrania was done within 48 hours of symptom onset. And this indicated really the NNT for this intervention was 2, which is impressive for the mortality. However, no patients achieved complete freedom of disability. You can see in the second figure, and although distribution of score on the MRS between the two treatment groups differ significantly between medical group and surgical group, but you can see in the second figure that 21% medical group versus 43% hemicrania group achieved MRS less than 4. In other words, significantly fewer patients had an MRS score greater than 3 at 12 months after surgical treatment versus medical treatment. So based on this data, before we go into that, timing of hemicrania is still uncertain within 48 hours. Probably you want to follow mental status, and decrease in mental status from the baseline is the marker that you should follow and then make a decision to go for hemicrania. And the size matters. Most studies recommend hemicrania more than 12 centimeter diameter. So American Heart Association recommendation is in patients less than 60 years of age who decompensate neurologically within 48 hours with brain swelling, they recommend decompressive crania with dural expansion as a reasonable therapy. Moderate recommendation and level of evidence is high. Destiny, the last trial I'll be talking about, Destiny 2 randomized control trial, 112 patients This trial focused on patients who are greater than 60 years of age. Primary endpoint of this trial was survival without severe disability, defined by MRS 0 to 4. At 1 year, there was a reduction in mortality by 50%, as you can see in the Kaplan-Meier curve. Survival benefit was pretty obvious, 76% in non-surgical group and 42% in surgical group when hemicrania was performed within 48 hours. However, you can see in the MRS in the first graph that the neurologic disability was pretty significant because none of these patients achieved functional independence at 1 year. Although there were more patients with MRS 3 or 4 in surgical group, but you can see no MRS 1 and 2 in this graph in Destiny 2 in both groups. So we need to carefully consider expectations, family wishes, and long-term quality of life. That's essential in discussing with the family and the medical team what to do with the decompressive hemicrania for patients greater than 60 years of age. So guideline says in patients greater than 60 years of age, the hemicrania with dural expansion may be considered with recommendation. Quality of life, we talked about quality of life a little bit, but there's a systematic review looking at quality of life after hemicrania. Surprisingly, a significant proportion of patients with moderate, severe, and well, that's not surprising, by the way, severe disability with high rate of depression long-term, but majority of patients and caregivers, about 80% expressed the satisfaction of life and had no regret of having undergone hemicrania. So more study is needed looking at quality of life on these patients. Conclusions: malignant MCA, infarct, and cerebral edema requires a comprehensive medical surgical approach with intensive care, frequent neuromonitoring, and early transfer to the centers with hemicrania expertise is recommended. Optimizing hemodynamics and physiology early after ischemic stroke is very important. ICU care, intensive care is the hallmark for these patients. Early identification and intervention, medical therapy, and also most importantly is hemicrania surgical intervention is a life-saving measure. Identifying ICF crisis is important, and the need for EVD invasive monitoring is also important. But we need further research. Primary prevention of brain swelling after injury is much more important than current reactive therapy strategy. Thank you so much for your attention.
Thank you, Sung-Min. Thank you very much. Really, two excellent presentations. We only have a few minutes for the question and answers, so I will go straight away to the first question. I think it's for Raimund, this one. So when to restart the anticoagulation, prophylactic and therapeutic, after different treatment methods? Choice of antiplatelets for secondary prevention? So management of anticoagulation therapy, basically.
So in the first 24 hours after thrombolysis, no anticoagulant treatment, no aspirin or antiplatelet treatment, and then it totally depends on the infarct size and on the etiology whether we go for anticoagulant treatment or thrombus inhibition. The second question was
choice of antiplatelets for secondary prevention.
So the primary choice is still thrombus, aspirin derivatives, and in case you have to apply a stent, then dual anticoagulant treatment, antiplatelet treatment is needed.
Okay, thank you. Very straightforward. In case of hypotension or normotension, what is the target of arterial blood pressure at which thrombolysis or recanalization can be started safely? And if you feel there is the need for fluids, which fluid is your first choice? I think it's still for Raimund.
So blood pressure below 185 for thrombolysis, and whenever you reperfuse, so when the recanalization is sufficient, I would target the blood pressure between systolic blood pressure between 140 and 160. The additional question?
Which type of fluid would you prefer as first choice if you feel that there is the need for fluid replacement?
So just a balanced fluid as they are available in the institution. So no saline, and obviously if you need plasma expanding fluids, then go for that.
Okay, thank you. Sung-Min, is tonsillar herniation a common occurrence with large MCA stroke? And if so, does this presentation look different to what you have described?
Yeah, I mean, tonsillar herniation can be seen, but it's not really common compared to midline shift and typical MCA infarct. And transtentorial herniation can occur if there is a significant edema. And again, I think mental status change is the hallmark because with the thalamus and all the reticular activating system all crowded in the midline structure with midbrain. So really, mental status change is the hallmark for any brain compression.
Okay. So still regarding the issue of cerebral edema, Sung-Min, there is a the $1 million question. So the CO2 management. Someone is asking regarding how to manage the cerebral vasodilation caused by CO2 and its relationship with the pH. An example could be in patients with COPD, where we generally have chronically increased the CO2 and bicarbonates. So the question is, can we tolerate high CO2 as long as the pH is in range? Or should we turn the patient alkalemic to lower the CO2?
Yeah, of course. This is $1 million question. Actually, I'm speaking in front of an expert, Dr. Roba here. But really, we don't have a lot of data. If a COPD patient is there and is compensated and pH is normal, then I think we should tolerate that CO2. And really, the patient's autoregulation function, we don't know what it is. And I think it emphasizes the role of bedside autoregulation monitoring, what the optimal target map and blood pressure target is. So in this situation, COPD or ARDS patient, another permissive hypercapnia patients, really we don't have a lot of data, but whatever they came with, I guess we will start from there. But I think I want to emphasize that we need further research and really optimal individual basis autoregulation monitoring and target the optimal blood pressure. Sorry, I'm not giving the answer, but yeah.
Probably because there is not a definitive one. And still, I mean, there are a lot of questions about the management of cerebral edema. We are already running late, so I have to choose one last question. It's about the use of hypertonic saline. Hypertonic saline 7.5%. Is it, here the question is 30 milliliters per hour guided by serum osmolarity and the serum sodium, or which is your practice? I mean, to understand which is the dose, the velocity.
Right. That's a commonly asked question. I think it really depends on what kind of hypertonic solution you have in your shop, right? In Hopkins, we have 2%, 3%, and 23.4%. Really, we use 23.4% when there is a refractory ICP crisis and you're noticing Cushing's and you have a brain herniation in the CT scan with depressed mental status. Then we usually use 23.4% in acute management phase. and 3%, 2%, we use it to maintain a certain threshold for the sodium. This is a controversial topic too, but you know, some intensivists, they target certain sodium threshold to maintain that level, but there's really no data to guide which target is the best. And as I said before, prophylactic hypertonic solution or hyperosmolar therapy is not really recommended.
Yes, thank you. I'm afraid I have to wrap up because we are running late. I really would like to thank both of you. Thank you, Raimund. Thank you, Sung-Min. Really two excellent presentations, and I think really useful for the clinical practice. Very direct and straightforward for what we concern, which is patient's care. A lot of people are asking whether the slides will be available, but I just want to ensure that the webinar will be available on replay on the website of ESICM. So don't worry, you can watch it once again. And I would like to thank all the attendees. I know that there are many people who have listened to your talks, and I'm very happy because, again, I'm very proud of this webinar. We have been excellent. Thank you very much to all of you. Thank you to the presenters. Thank you to ESICM and to the next section for the opportunity to organize this webinar. And I hope we will meet in person very soon to discuss further about stroke management. Thank you, guys.
Thank you.
Thank you very much. Bye-bye.